Welcome to the class now for the endocrine system. We are going to do this class in 3 parts. Today, in this particular lecture, we are going to look at introduction to the endocrine system. After that, we are going to look at basically the hypothalamus, the pituitary, and the pineal gland in this particular class. Then in the subsequent classes, we'll do the other endocrine organs. So just as a matter of introduction, we are aware that cells in the body can communicate with one another. One cell can communicate with another one. We see that a lot in the white blood cells. Cells with the immune system, they communicate by releasing some chemicals that influence another cell. That concept of cells communicating with one another is what is called intercellular communications, or you can call it cell-to-cell communication. There are different types of intercellular communications. We categorize intercellular communications based on whether the cells communicating are in contact or not. According to this classification, we have 2 types of communication: direct intercellular communications and indirect intercellular communications. When you talk of direct intercellular communications, these are communications where the 2 cells which are communicating are physically linked, which means they're in contact with one another. And there are different varieties of direct intercellular communications. The cells can communicate using gap junctions. So molecules move freely from one cell to another through some channels. We see this a lot in smooth muscle, in cardiac muscle, and in some neurons. They can also have communication where the 2 cells are linking transiently using some surface markers. We see this a lot in the white blood cells. And lastly, the 2 cells can communicate using what we call nanotubes, and these one usually involve movement of organelles from one cell to another. These are direct intercellular communications. How about the indirect intercellular communications? In the indirect type of intercellular communications, the 2 cells are not physically linked. And if they're not physically linked, then it means that they have to use a chemical that moves some distance so that that chemical can reach the target cell. So the cell that will be releasing, it will be there, but there's a chemical that must move some distance. The concept here is that that messenger must move some distance because the 2 cells are not physically linked. Now, based on the mechanism of the movement of the chemical messenger, then we can have different types of chemical signaling, but we'll be revisiting that shortly. Let me elaborate on the concept of intercellular communication, of indirect intercellular communication. Consider that you have 2 cells. This one cell and the other one, and we've mentioned that they're not physically linked. So there's some distance between one cell and another one, but remember, they're both within the body. If they're not physically linked, the only way they can communicate is using chemical messenger. The other name given to chemical messengers is ligand. They can only communicate using ligands. Now, one cell must produce the chemical messenger, and the other cell must respond to that chemical messenger. The cell that produces the chemical messenger is termed the secretory cell. And the cell that responds to that chemical signal is called the target cell. In principle, the target cell contains receptors for that chemical messenger. So if a cell does not contain receptors for a chemical messenger, it is not a target cell. And if a cell contain the receptors for a particular chemical messenger, then it's a target cell. Importantly, you realize that the target cell is the one that responds to the communication that has come. So if the secretory cell produces a chemical messenger, the target cell is the one that will have those biological responses. Maybe it can respond by producing another thing, by moving from one point to another, by opening some ion channels, whatever it does. But the target cell is the one that actually experiences the biological effects of the chemical messenger. So with that in mind, therefore, there are different types of chemical signaling mechanisms. This concept of cells producing a chemical messenger to act on another cell, there are different types. The first type is what we call autocrine signaling. In autocrine signaling, the secretory cell produces chemical messenger, as you can see in this image, but that very cell, that is the secretory cell, also contains receptors for that chemical messenger, which means that the chemical messenger acts on the same cell. So we call that autocrine signaling, if the secretory cell is also the target cell. Second type of chemical signaling is where the secretory cell and the target cell are actually next to each other. So they are actually in physical contact, except that we're using chemical messenger. So in this concept, the secretory cell produces the chemical messenger, but the target cell is just next. So the chemical binds to the receptors on the target cell. We call that juxtacrine signaling. You realize, therefore, that juxtacrine signaling is just an example of direct intercellular communications where they use some surface markers. But let's think about the other two. This is what we call paracrine signaling. In paracrine signaling, the chemical messenger is released, but that chemical messenger must travel some short distance because the target cell is not in contact with the secretory cell. Although the target cell is not in contact, it is just within the neighborhood. If the target cell is within the neighborhood, how will this chemical messenger move? It will move through diffusion. So the chemical messengers diffuse through the extracellular fluid matrix. If that is the story, then we call that paracrine signaling. You realize, therefore, that paracrine signaling is an example of indirect intercellular communication. Now, these three are not our subject matter of discussion. The one which is our subject matter of discussion is endocrine signaling. When do we call it endocrine signaling? We call it endocrine signaling if the secretory cell and the target cell are far away from each other. So the only way that the chemical messenger can travel to ever reach the target cell is if that chemical messenger is released into the bloodstream. So in that concept, we call that endocrine signaling, where the chemical messenger is released by the secretory cell into the bloodstream. So the chemical messenger travels through the bloodstream to reach the target cell. So as I've already mentioned to you, A target cell must contain the receptors for the chemical messenger, even if it is through this bloodstream that the chemical message is traveling. Like in this case, this is secondary cell releasing chemical signal that go through the bloodstream to reach the target cell. So this is target cell, it has the receptors. The receptors can either be on the cell membrane or they can be intracellular. Now, which kind of chemical messengers will have their receptors on the cell membrane? Chemical messengers which are basically proteins, they'll tend to have their receptors on the cell membrane. Why is that so? Proteins are not able to go through the cell membrane because remember the cell membrane is a phospholipid bilayer structure. So the proteins are not able to pass through the cell membrane. For that reason, protein chemical messengers mostly have their receptors on the cell membrane of the target cell. That's a bit different from chemical messengers which are lipids in nature. The chemical messengers which are lipid in nature are able to pass through the cell membrane because the cell membrane is a phospholipid bilayer, so they're able to diffuse through the cell membrane. So those chemical messengers have their targets, have their receptors inside the cell as opposed to be on the cell membrane. Capture that. As we discuss the concept of endocrine system, I want to bring to your attention the difference between an endocrine gland and an exocrine gland so that we don't mix the two. An exocrine gland is different from an endocrine gland. An exocrine gland usually produces body fluids, but an endocrine gland produces hormones. That chemical messenger that is released into the bloodstream is what we are calling a hormone. So the glands that produces these chemical messengers into the bloodstream are called endocrine glands. That is different from exocrine glands that produce body fluids. Now think about what are body fluids generally. Now the body fluids which are released by exocrine glands usually are released into a ductal system so that they can travel along those ductal systems into epithelial surfaces. Yet, on the other side, for endocrine glands, the hormone is released into the bloodstream so that that hormone can travel all the way to its target cell. So if you have understood that, let me give you a few seconds to then give examples of exocrine glands so that you don't confuse them with the endocrine glands that you have in mind. So you have a few seconds to just list down the exocrine glands. You don't have to list 6, you can list as many. So we can now continue with our subject matter for endocrine glands. Endocrine glands produce hormones. That chemical messenger is called a hormone. We can define hormones as biological chemical messengers that are released into the bloodstream so that they can act on distant target organs. We classify hormones based on their biochemical structure. Well, there are many ways of classifying hormones, but the one I want to highlight is the one based on biochemical structure. We have what we call steroid hormones. Steroid hormones are hormones which are derived from cholesterol. So they are lipids in nature. They are made from cholesterol. Examples of steroid hormones include gonadotropins, which are things like testosterone, dihydrotestosterone, estrogen, progesterone, and the like. They are steroid hormones. Apart from gonadotropins, you also have the corticosteroids. Corticosteroids are hormones from the adrenal cortex. They are steroid hormones from the adrenal cortex. So we do have things like aldosterone, which is an example of a mineralocorticoid, and cortisol, which is an example of a glucocorticoid. Those are steroid hormones. In principle, steroid hormones are able to go through the cell membrane to enter into a cell. And for that reason, steroid hormones have their receptors inside the cell. They have intracellular receptors. Second category are hormones which are amino acid analogs. They are analogs of amino acid. And the hormones which are analogs of amino acid, the amino acid in question here is tyrosine and tryptophan. The hormones derived from tyrosine are thyroid hormones. We have what we call T3 and T4. And we have the catecholamines, adrenaline, noradrenaline, and dopamine. Those are catecholamines. Those ones are derived from tyrosine. The ones derived from tryptophan are serotonin and melatonin. In general, these are now the hormones derived from amino acid analogs. Lastly, we have hormones which are peptides and glycoproteins. A peptide hormone is a hormone formed from chains of amino acid. It could be long, short, whatever, but they're amino acid chains. So they're basically proteins. We give it a name glycoprotein if that amino acid chain contains a carbohydrate side chain. Then you call it glycoprotein. There are several hormones which belong to this category. Pituitary hormones, like the ones we're going to do today, belong to this category. We'll be talking about them. Pancreatic hormones like insulin, glucagon, they also belong to this category. In principle, again, peptides and glycoproteins are not able to pass through the cell membrane. For that reason, they usually have their receptors inside the cell, on the cell membrane. Because they cannot go through the cell membrane, so their receptors are on the cell membrane. Great. There are two types of endocrine systems that I want to teach you. We have what we call the discrete endocrine system and the diffuse endocrine system. In the discrete endocrine system, the endocrine cells, the cells that produce hormones, are clustered together so that they now form what we call an endocrine gland. So the endocrine cells are clustered together, they are grouped together to form an endocrine gland. That's a discrete endocrine system. But there's another form of endocrine system where the endocrine cells are not grouped together. And so there's no endocrine gland per se, but there's still hormones being produced. That type of endocrine system is called the diffuse endocrine system. So for the diffuse endocrine system, in most cases, this is the story. The endocrine cells are dispersed, and usually they're dispersed on epithelial surfaces. So they're found on epithelial surfaces. Most of them are on the wall of the GIT. That's where most of them are found. But the endocrine cells are just scattered on epithelial surfaces. It is actually said that if you were to group all the endocrine cells along the GIT wall, it may perhaps form the largest endocrine organ in the body. But yes, we know that the cells are scattered. So they're not forming an endocrine gland. Now, some of the diffuse endocrine system may belong to this category that we call the diffuse neuroendocrine system, also known as DNS, where the cells produce hormones in response to nerve signals. So we call that DNS, diffuse neuroendocrine system. They produce hormones, those scattered cells produce hormones in response to nerve signals. You may have come across something called APUD. Some of these cells belong to that category again. APUD, APUD, meaning amine precursor uptake and decarboxylation. Amine precursor uptake and decarboxylation. Some cells in this category belong to that system called APUD, amine precursor uptake and decarboxylation. Now, that comes from the concept that the cells which belong to the diffuse endocrine system, some of these cells usually take up amines as their precursors. And then they cause decarboxylation on the amines. So they decarboxylate the amines. So they're called amine precursor uptake and decarboxylation system, APUD system. All right, now I hope you well been introduced to the endocrine system. The subject matter of this class is to talk about the discrete endocrine system, where we are going to talk about endocrine glands. Specifically, in this class, we will be looking at hypothalamus, pituitary, and pineal gland. Then subsequent classes, we look at the others. So we don't have to then name those endocrine glands anyway. I can just give them to you right away. So in the head region, those are the ones you're going to do today. Hypothalamus, pituitary, and pineal gland. In the neck, we have two that we'll be doing, thyroid and parathyroid. In the abdomen, there are two that we look at, pancreatic islets of Langerhans and the adrenal gland. And lastly, in the pelvis, for lack of a better term, I'm calling pelvis, we look at two again, the ovary and the testes. I'm saying for lack of a better term because we know that the testis is surely not in the pelvis. But now we can't say it's outside the body. So let's go with that. All right, so what is the main objective of discussing each of these endocrine glands? Now, this is what is expected of you. For each endocrine gland, you need to know the location. Where is that endocrine gland found? Then you need to know the gross anatomical parts, if that is applicable. There are some glands where it may not be applicable, but where applicable, you talk about it. Then within that gland, from a histological perspective, there are some cell types. And the cell types here are the cells that produce hormones. So we are not talking about the stromal cells, the connective tissue cells, no. We are talking about the parenchymal cells, the cells which produce hormones in that gland. Which are these cells? So they have names. We'll be giving names to those cells. And then we'll also be indicating the type of hormone those cells produce. And then we go ahead to talk about the target organ of those hormones. Where are those hormones acting? And we talk about the physiological effects of those hormones on their target organs. And lastly, because we are learning to be clinicians, we want to know what happens if you have a problem with that particular hormone. What kind of clinical aspects can we mention related to disorders of those hormones? So that is our learning outcome for each of the endocrine glands. Let's start with the first endocrine gland, which is the hypothalamus. So in terms of location, we know that hypothalamus is part of the encephalon. Remember the other component, the encephalon, thalamus, subthalamus, and epithalamus. So hypothalamus is one of the components of the encephalon. Hypothalamus has several functions. From your neuroanatomy, neurophysiology, you understand that. One of the key functions of hypothalamus is endocrine function. And that's what I want to debate on. The endocrine functions of the hypothalamus are in twofold. In one way, hypothalamus produces hormones which regulate the hormonal secretions of the anterior pituitary gland. So this organ here produces hormones which travel to the anterior pituitary gland to control the hormonal secretions of the anterior pituitary gland. The category of hormones that will promote secretions of anterior pituitary hormones are called releasing hormones. The category of hormones that will inhibit the release of anterior pituitary hormones are called inhibiting hormones. So hypothalamus produces hormones which control the hormonal secretions of the anterior pituitary. That is one way. And there are several hormones. But the other way is this. Hypothalamus produces hormones which travel via nerves to reach the posterior pituitary to be stored there. So those ones are produced in the hypothalamus, but they become stored within the posterior pituitary. We call these two hormones oxytocin and vasopressin, which is also known as the antidiuretic hormone. So that is the other way in which hypothalamus exerts its endocrine role. Now, what do you notice? Pituitary doesn't really produce hormones without instructions from the hypothalamus. It is for that reason that we've stopped calling the pituitary gland the master endocrine gland. We now know that hypothalamus is actually the master endocrine organ because it controls the pituitary hormones. Great. So there are several hormonal factors that come from hypothalamus to go to the pituitary. The ones that go to the posterior pituitary, which is called neurohypophysis, are oxytocin and vasopressin, which is also called antidiuretic hormone. The ones which go to the anterior pituitary, which is also called adenohypophysis, are these ones. We have corticotropin releasing hormone, thyrotropin releasing hormone, gonadotropin releasing hormone. And I hope you understand. So if you say corticotropin releasing hormone, it means it causes the release of corticotropin, which is also called Adrenocorticotropic hormone. Thyrotropin releasing hormone causes the release of thyrotropin from the anterior pituitary. Thyrotropin is also called thyroid stimulating hormone. Gonadotropin releasing hormone causes the release of gonadotropic hormones. The gonadotropic hormones are luteinizing hormone and follicle stimulating hormone. Growth hormone releasing hormone promote release of growth hormone. Growth hormone inhibiting hormone inhibits the release of growth hormone. Prolactin releasing factor promote the release of prolactin, and prolactin inhibiting factor inhibits the release of prolactin. So these are the hormones that hypothalamus produces to go to the anterior pituitary. And these are the hormones the hypothalamus produces to go to the posterior pituitary. Having said so, we realize that we cannot really discuss the hormones of the hypothalamus unless we really understand the hormones of the pituitary gland. So let's talk about the pituitary gland. This is how it looks like histologically. What do you see? We see an organ with the two parts. One is more fibrous and the other one is more cellular. It is encapsulated. It's covered by a capsule. In this view, we also see that one side is more fibrous and the other side is more cellular. And there's a cleft between. That is how the pituitary gland looks like histologically. It is located in the in the middle cranial fossa at that point. We locate it there, middle cranial fossa. That specific region of the middle cranial fossa is called the sella tussica. It's at the base of the brain, as you can see here. This is the pituitary gland at the base of the brain, just below the hypothalamus, which is this one, or that one, pituitary gland. This is hypothalamus. On MRI, you may see the posterior aspect of the pituitary gland having that bright spot. We call the pituitary bright spot, which represents the neurohypophysis. And then this other one is adenohypophysis, the anterior pituitary, but that's the pituitary gland. As I've mentioned to you, the pituitary has two parts, adenohypophysis for anterior pituitary and neurohypophysis for the posterior pituitary. We usually talk about each of those two parts having other parts. So what are the parts of the adenohypophysis, the parts of the anterior pituitary? We have this one, which we call the pars distalis. And we have this one, the one that's around the stalk of the pituitary, so we call it the pars tuberalis. And there's a portion of the adenohypophysis which is next to the neurohypophysis. We call the pars intermedia. So pars tuberalis encircle the stalk. Pars intermedia is next to the neurohypophysis, and pars distalis is on its own. So that pars distalis is actually what is normally known as the anterior lobe of the pituitary gland. In this image, which has been cut through here, so this is pars distalis. This is the intraglandular cleft. This is part of neurohypophysis. I'll give you its name shortly, but this stripe here is the stripe of the pars intermedia. You notice that pars intermedia, although part of adenohypophysis, it is on the posterior aspect of the cleft. This cleft is a remnant of embryological structure called the Rathke's pouch, a structure that formed the pituitary gland. And so because it's a pouch, the wall, the anterior wall becomes this pars distalis, and the posterior wall of the pouch becomes the pars intermedia. How about the neurohypophysis? The part of the neurohypophysis are these ones. So this is pars nervosa, which is this one actually. And we call this one the infundibular stalk. And usually we also consider this one, the median eminence, as part of the neurohypophysis. Median eminence, infundibular stalk, and pars nervosa. The median eminence is also considered part of the hypothalamus. It is the part that now gives you the pituitary stalk. Great. We had already looked at that also. So this is neurohypophysis. So that would be the pars, the infundibular stalk. That is median eminence, infundibular stalk, and pars nervosa. This is pars distalis. This is the pars intermedia, and that is the cleft. So remember our objective for each gland we mentioned that for each gland, we need to talk about one, the location, the gross anatomical parts, the cell types of the parenchyma, the target organ, the cell types of the parenchyma, the hormones those cells produce, the target organ of the hormones, the physiological effects of the hormones, and anything clinical we can highlight. So the gland in question is pituitary gland at this point. We've mentioned where it is found. Hypophyseal fossa, just below the hypothalamus. The gross anatomical parts, we've mentioned that there are two parts, Adenohypophysis and Neurohypophysis. In terms of the function of cells, there are many varieties, but these cells usually will depend on which part. So there are cells of the Adenohypophysis and there are cells of the Neurohypophysis. They are different. For that reason, even the hormones will be different. So I want us to tailor our discussion based on that. We start with cells of the Neurohypophysis, then we look at cells of the Adenohypophysis. Neurohypophysis contain neuronal cells, and that is why it's called neurohypophysis. So the cell types are actually neurons. But where are the cell bodies of these neurons? The cell bodies of these neurons are up in the hypothalamus, in those two nuclei. The paraventricular nucleus of hypothalamus give you axons that go to the posterior pituitary. Also, the supraoptic nucleus of the hypothalamus give you axons of neurons that go to the posterior pituitary. So the cell types of the neurohypophysis are neurons whose cell bodies are in the hypothalamus, specifically in the paraventricular and supraoptic nucleus. These cells produce and store oxytocin and antidiuretic hormone. So the two hormones are produced up here, but the hormones will be stored at the axonal terminals of those neurons, which means what? That the hormones must travel through the axons of neurons to reach the posterior pituitary. This axonal connection between the hypothalamus and the posterior pituitary has a name. We call it hypothalamo-hypophyseal tract. The name of the axonal connection between the hypothalamus and the pituitary gland is called hypothalamo-hypophyseal tract. Hypophyseal is a name for the pituitary. We call it hypophysis cerebri, downgrowth from the cerebrum. Hypo means down, physis means growth. So hypophysis cerebri means downgrowth from the cerebrum. And so hypothalamo-hypophyseal tract is that tract that connects hypothalamus and the pituitary gland. Those two hormones are stored in the posterior pituitary. So this image shows you that concept. In particular, we note that the paraventricular nucleus of the hypothalamus is the one that produces antidiuretic hormone. The supraoptic nucleus of the hypothalamus is the one that produces oxytocin. And then these hormones are the ones that travel down along the axons of neurons. So the tract to reach the axonal terminals of those neurons, they'll be stored there. These hormones will be released into the bloodstream within posterior pituitary gland when they're required. But if they're not required, they remain in the axonal terminals of those hormones, those neurons. So note that pituitary gland does not really synthesize them, it only stores them. Let's discuss the two hormones. We start with oxytocin. So oxytocin is produced by the supraoptic nucleus of the hypothalamus. Those are the cells that produce oxytocin. Oxytocin acts on the myometrium, which is the smooth muscle of the uterine wall. The physiological effect is to cause uterine contraction. The other target of oxytocin is the breast myoepithelial cells. The physiological effect is to eject milk. How about antidiuretic hormone? The secretory cell is the paraventricular nucleus of the hypothalamus. Antidiuretic hormone act on the renal tubules, especially on the collecting ducts and perhaps the collecting tubules. The physiological effect is water reabsorption. It is for that reason that we call it antidiuretic hormone, because it means it prevents diuresis, loss of water in urine. Then ADH also acts on blood vessels. It causes vasoconstriction, and that makes the lumen of the blood vessel narrow, so increasing resistance of the blood vessels. Because of that, we call it vasopressive. All right. Think about the clinical effects related to antidiuretic hormone. If you have deficiency of antidiuretic hormone, this patient will be producing a lot of water in urine, be losing a lot of water in urine. We call that diabetes insipidus. However, there are some cancers which are also associated with abnormal secretion of antidiuretic hormone. So think about what will happen if you have excess antidiuretic hormone. Those conditions of excess antidiuretic hormone are called syndrome of inappropriate antidiuretic hormone secretion. Syndrome of inappropriate antidiuretic hormone secretion. So those are the two clinical entities I want you to know regarding ADH or vasopressin. So we have talked about neurohypophysis. We've talked about the functional cells. We've said they're neurons, and that the hormones that produces two hormones, oxytocin and antidiuretic hormone. Now let's revert our attention to here. Adenohypophysis. Adenohypophysis contains cells which produce trophic hormones. These trophic hormones are produced in response to the signals which came from hypothalamus. Remember, the signals are either a releasing signal to promote release of a particular hormone, or inhibiting signal to inhibit the release of a particular hormone. Look at this image. So we have neurons from, okay, maybe start with this one. We have neurons from the hypothalamus, which produce hormones into the bloodstream within the hypothalamus. And then those hormones travel through the bloodstream to reach the anterior pituitary gland. Now we can use this other image. Neurons in the hypothalamus producing hormones into the bloodstream within the hypothalamus. Then those hormones which have been released in the bloodstream travel through vascular channels to reach the capillary plexus within the anterior pituitary gland. Those hormones then act on the endocrine cells of the pituitary gland, so that now pituitary gland can now produce hormones of its own into the bloodstream again. These hormones from the hypothalamus are either releasing or inhibiting signals. And I hope you understand what that means. The releasing hormones will cause this cell to produce a hormone or to release it. The inhibiting one will inhibit the release of that hormone into the bloodstream. We realize, therefore, that between the hypothalamus and the anterior pituitary gland is a vascular connection as opposed to axonal connection. The name given to the vascular connection between hypothalamus and the anterior pituitary gland is hypophyseal portal system. Hypophyseal portal system. That's the name given to the vascular connection between the two organs. So don't confuse hypophyseal portal system that goes to the anterior pituitary with hypophyseal tract, which goes to the posterior pituitary. What are the cell types of the anterior pituitary? We classify the cell types of the anterior pituitary based on their staining characteristics. They are those cells which are able to pick up the dyes that are in the stains. They are called chromophils. And there are those ones which don't take up the dyes. They are called chromophobes. The chromophils are further classified based on the type of dyes that the cells like. There are some cells that like the acidic dyes. So they're called acidophils. There's some cells that are stained with the alkaline dyes. We call them basophils. The acidophils and the basophils are the cells which produce hormones from the anterior pituitary. The chromophobes do not produce hormones. Now, the acidophils and the basophils can be further classified based on the type of hormone they produce. Remember, those hormones are stored within their secretory vesicles, or what you can call secretory granules. So based on the type of granules that a cell contains, we can further subclassify the acidophils and the basophils this way. For the acidophils, there are two varieties. We have what you call somatotrophs and lactotrophs. Why are they given these names? Somatotrophs produce somatotropin, which is the growth hormone. Lactotrophs produce lactotropin, or you can call it mammotropin, which is called prolactin hormone. Let's discuss those two hormones first. We start with the growth hormone. Growth hormone comes from the somatotrophs, as you said. It's a type of acidophil. The target tissue of growth hormone is muscle and bone. The physiological effect is to promote growth of muscle and bone. Well, to also promote cell division. Growth hormone also acts on the liver for carbohydrate metabolism, usually elevating the levels of glucose in bloodstream. So if you think through that, the clinical aspects related to growth hormone will be based on the first column. If you have growth hormone deficiency, you'll expect to have dwarfism. And if you have growth hormone excess, you'll have gigantism. If this manifests early in life before the person finished growing, that means in a younger person, or acromegaly if it has a late onset, which means that someone has growth hormone excess after they have reached adulthood, for example, or let's say when the growth plates have already fused. So gigantism is a term given when you have growth hormone excess in early development in a child. acromegaly is the term given to growth hormone excess when it happens at a late onset. As with regard to carbohydrate metabolism, if you have growth hormone excess, you may have a lot of glucose in the circulation. That would be diabetes, but that type of diabetes is called secondary diabetes. So the images here show you on your left, someone with acromegaly. We call it acral with reference to the couple bones, which are usually very prominent. You can see the hand of this person is covering one hemithorax, almost. And this other image shows you a patient with the gigantism. The whole person actually just becomes massive. The other hormone to talk about from acidophils is the prolactin hormone, which is also called mammotropin. It comes from the mammotrops, which are also called lactotrops. These are type of acidophils. This one targets the breast acinar cells. You can call them the lobular cells of the breast. These are the cells that produce milk. So the physiological effect is milk production. If you have an issue with prolactin, let's say you have excess prolactin, we call that hyperprolactinemia. How will hyperprolactinemia present? It will make this woman to be producing milk unusually when it's not expected. We call that galactorrhea. So those are the hormones which come from the acidophils: growth hormone and mammotropin, or what we call prolactin. We can now therefore look at the basophils. There are three types of basophils. There are those that are called thyrotrophs. We have corticotrophs and gonadotrophs. The thyrotrophs produce thyrotropin, and that's why they're called thyrotrophs. The hormone thyrotropin is also called thyroid stimulating hormone. Corticotrophs produce corticotropin. The hormone corticotropin is also called Adrenocorticotropic hormone, ACTH. The gonadotrophs produce the gonadotropic hormones. There are two gonadotropic hormones: follicle stimulating hormone and luteinizing hormone. So let's discuss these hormones one by one. We start with TSH, which is also called thyrotropin. So the cells which produce TSH are the thyrotrophs, which are a type of basophils. The target organ of TSH is the thyroid gland. And in particular, TSH acts on what we call the follicular cells of the thyroid gland. We are going to see that in the next part that thyroid gland has two kinds of cell types, follicular and parafollicular cells. TSH acts on the follicular cells of the thyroid gland. The physiological effect of TSH on thyroid gland is to stimulate the production of the thyroid hormones T3 and T4. T3 is known as triiodothyronine, and T4 is known as tetraiodothyronine, or commonly we call it thyroxine. So in the presence of TSH, the thyroid gland responds by producing the thyroid hormones. And so in terms of clinical aspects, if you have excess secretion of TSH, it means that the thyroid gland may be stimulated to produce a lot of T3 and T4. And that is what we call hyperthyroidism. Again, if the levels of TSH are low, the gland is understimulated, you may have low levels of T3 and T4, and that is what we call hypothyroidism. So understand the definition of hyperthyroidism and hypothyroidism is based on the concentration of the T3 and T4 in the circulation. If the levels are high, we call that hyperthyroidism. And if the levels are low, we call that hypothyroidism. It's a laboratory finding. It's not a clinical diagnosis, but yes, it will have clinical manifestation. Now, thyroid disease can be of two different types. We have what we call the primary thyroid disease and the secondary thyroid disease. A primary thyroid disease is where you have either hyperthyroidism or hypothyroidism because of a problem intrinsic to the thyroid gland. That would be a primary thyroid disease. On the other hand, a secondary thyroid disease is where we have whether hyper or hypothyroidism, and this is because of defective stimulation process. Either it's hyperstimulated or hypostimulated. And so you realize that you call it secondary thyroid disease if the problem is either coming from the hypothalamus or from the pituitary gland. And we call it secondary thyroid disease if the problem is either coming from hypothalamus or pituitary gland. And we call it primary thyroid disease if the problem is intrinsic to the thyroid gland itself. We'll discuss more about hyperthyroidism and hypothyroidism, the different types, when we discuss thyroid gland. This is how people with hyperthyroidism sometimes may present clinically. Usually, they have this kind of propping eyes, what we call proptosis or exothalamus. This is very characteristic of thyroid disease, hyperthyroidism to be particular. The second hormone from the basophils is the Adrenocorticotropic hormone, which is also known as corticotropin. This hormone comes from the corticotrophs. The hormone targets the adrenal cortex. So it goes to the adrenal gland fine, but the adrenal gland has two zones. The outer zone is called the adrenocortex. The inner zone is called the adrenal medulla. ACTH acts on the adrenal cortex. When we discuss the adrenal gland, you'll note that the adrenal gland, the cortex of the adrenal gland has three layers. We have the outermost layer called zona glomerulosa, middle layer called the zona fasciculata, and the inner layer called zona reticularis. ACTH does not necessarily act on the whole of the adrenal cortex per se. Principally, it acts on the second layer of the adrenal cortex, which we call zona fasciculata. So that's the target organ, zona fasciculata of the adrenal gland. The physiological effect on the zona fasciculata is to stimulate the production of glucocorticoids, hormones which affect glucose levels, glucocorticoids. A good example of a glucocorticoid is cortisol hormone. So ACTH stimulates production of cortisol. And so in terms of disorders, if we have excess ACTH, it means that the adrenal cortex may produce excess cortisol, and the term given to that is hypercortisolemia. In conditions of hypercortisolemia, a patient may have some characteristic clinical entity that we call Cushing's syndrome. So Cushing's syndrome is usually a metabolic disorder characterized by abnormal deposition of fat and, of course, abnormal glucose metabolism as well. Now, in that context of hypercortisolemia, patients with the hypercortisolemia may also have excess levels of glucose. So we call that diabetes mellitus. But this type of diabetes mellitus is not the one related to the insulin. So we don't call it primary, we call it secondary diabetes mellitus. So these images show you images of individuals with Cushing syndrome. What we capture is abnormal fat deposition. So you would have hoped that there'll be fat there, but that's where it's lacking. And then you don't want this one, but that's where the fat is located. You also don't want fat here, but that's where fat is. As you can see there, there's some bumps. Okay, the third hormone, follicle stimulating hormone, which is a type of a gonadotropic hormone. So FSH comes from the gonadotropes, which are a type of basophils. The target organ of FSH, from the name gonadotropic, it means that it will be targeting the gonads. And remember, we have two gonads. The female gonad is the ovary. The male gonad is the testis. So on the ovary, FSH usually causes follicular maturation or development of the ovarian follicles. You can call that folliculogenesis. And remember, this is what happened in the first half of the female reproductive cycle. And as the follicle matures in readiness for ovulation, the size of the follicle increases, and that means that the number of follicular cells increase, the number of granulosa cells increase. And as the number of granulosa cells increase, the levels of estrogen also increase. So we say that FSH also stimulates estrogen secretion. In the testis, FSH also has a role, and in particular, it stimulates the process of spermatogenesis. It promotes spermatogenesis. So with that in mind, if the levels of FSH are not normal, what should you expect? Perhaps abnormal menstrual cycles. Maybe the cycles disappear, or they're too frequent, or something like that. And it's also associated with infertility, because we can see it affects follicular as well as spermatogenesis, follicular development and spermatogenesis. Great. The last hormone from the basophils is luteinizing hormone, which is also a gonadotropic hormone, so coming from the gonadotropes. In the ovary, luteinizing hormone stimulates the process of ovulation. The luteinizing hormone surge is associated with ovulation process. Remember, when ovulation takes place, the egg is extruded. What remains inside the ovary is called the corpus luteum. The corpus luteum, those are the remnants of the follicle. Those remnants of the follicle usually undergo luteinization in the presence of luteinizing hormone. And after luteinization, it becomes corpus luteum fine. The corpus luteum produces progesterone at high levels. So now we switch gear from production of estrogen, well, still there, but low. There's more production of progesterone hormone. So we say luteinizing hormone promotes production of progesterone hormone. In the testis, luteinizing hormone promotes secretion of the androgenic hormones. Remember, androgenic hormones include things like testosterone and dihydrotestosterone. So their production is stimulated by luteinizing hormone. Again, if the levels of luteinizing hormone are not okay, you'll expect some abnormal menstrual cycles as well as infertility. Good, so that summarizes the story of the pituitary gland. But just to remind you something, remember, pituitary gland relies on hypothalamus for it to produce its hormones. Hypothalamus exerts control on the pituitary gland on two ways. To the adenohypophysis, which is the anterior pituitary, hypothalamus produces releasing and inhibiting factors which control the secretions of the anterior pituitary. So in particular, we have corticotropin releasing hormone, which stimulate the release of ACTH. We have thyrotropin releasing hormone, which stimulate the release of TSH. We have GnRH, gonadotropin releasing hormone, which promote the release of FSH and LH. We have growth hormone releasing hormone, which promote the release of somatotropin. We also have growth hormone inhibiting hormone, which inhibit the secretion of somatotropin. We have prolactin releasing factor, which promote the release of mammotropin, and prolactin inhibiting factor that inhibit the secretion of prolactin hormone. So these are hypothalamic hormones. They come from the hypothalamus and they travel to the anterior pituitary via the hypothalamo-hypophyseal portal system. Then we have the hormones which go to the neurohypophysis. Those ones are produced by the hypothalamus and carried by the axons of neurons. The axonal connection between hypothalamus and pituitary is what we called the hypothalamo-hypophyseal tract. So those hormones are carried through those neurons to the neurohypophysis. There are two hormones, oxytocin and vasopressin, which is also called antidiuretic hormone. And we've discussed those hormones. So that is pituitary gland. Let's talk about the third gland in the head region, and that is the pineal gland. In terms of its location, pineal gland is part of the diencephalon. It's located just behind the thalamus. This is the pineal gland. Remember, that's the thalamus. This is pineal gland. That's the thalamus. This is hypothalamus. This is pituitary gland. This is midbrain. So you can see the tectum of midbrain and the tegmentum of midbrain. The pineal gland is just above the tectum of midbrain. This region here is the region of the third ventricle. If you imagine that you have the right and the left thalami, the space in between is the third ventricle. See, just behind the third ventricle there. As someone grows, the pineal gland may develop some calcification, and it's a normal thing. So on CT scan, pineal gland will appear as a bright spot, like that one on this axial CT scan of the head, or this one on this sagittal CT scan of the head, or that one on this coronal CT scan of the head. Well, you're also seeing another calcification inside the ventricle. This is for choroid plexus. But now that is the pineal gland. This is a midline structure. In terms of shape, the gland is ovoid or pear-shaped and very tiny, really. The principal cell types within the pineal gland are called pinealocytes. These are the cells which produce hormones, pinealocytes. Okay, so this is where we are. We've talked about its location. We've talked about the gross anatomy, nothing about the parts really, but yes, we talked about the shape and the functional cell types. So which hormone comes from the pinealocytes? The hormone produced by the pinealocytes is melatonin hormone and serotonin, although even that serotonin is still converted to melatonin. So let's just work with melatonin. The effect of melatonin is experienced in the hypothalamus as well as in the hypothalamo-hypophyseal gonadal hormonal axis. Now let's start with the effect on the hypothalamus. On the hypothalamus, melatonin regulates the circadian rhythm. The circadian rhythm is a day-night rhythm. This one tells you that it's now daytime, you should be awake, or night, you should be asleep. On the hypophysial gonadal hormonal axis, melatonin generally inhibits the secretion of the gonadotropic hormones. So it suppresses that axis. And by suppressing that axis, then it means that we will not have high levels of estrogen, progesterone, and androgens. The aim of this is to basically delay the onset of puberty until the appropriate age. And so melatonin secretion will be able to delay the puberty onset until the appropriate age. The other clinical effect or other physiological effect of melatonin hormone, which is not captured here, is on its effect on the immune system. Melatonin modify the immune system. So think about the related clinical disorders based on these two functions I've given you. So as with regard to it controlling circadian rhythm, we'll expect that if you have abnormal levels of melatonin, then you'll have sleep disorders. So deficiency of melatonin is associated with less sleeping, which we call insomnia. Deficiency of melatonin is also associated with early onset of puberty. That's what we call precocious puberty. These images show you images of children who have precocious puberty. Look at this first one. A young boy, but already we can see hair growth. So puberty is already setting in. That's precocious puberty. This one's a very young girl, and we already see development of the breast, early onset of puberty. So we call this precocious puberty. Great. So that's the end of the first part of the lecture series on endocrine system.